My presentation is about superior semicircular canal dehiscence. For this presentation, I will call this disease SSCD. The presentation is comprised of three parts. I will start with a brief review of the disease. SSCD is a part of the spectrum of a third window abnormalities. It is caused by focal loss of the bone wall of the superior semicircular canal. Dehiscence causes decreased air conduction and increased bone conduction in third window anatomy. The prevalence of SSCD has been reported as 2.1 to 10.7% on temporal bone CT scan, and also 0.5 to 0.6% at the post-mortem studies. Incidence is as high as 10% in children. Highest incidence is in children younger than 2 years of age. These statistics provide support for both congenital and acquired etiologies. SSCD symptoms are characterized by cochlear and vestibular signs. Cochlear signs include conductive hearing loss, pulsatile tinnitus, orthophony, hyperacusis, and otophones. Vestibular signs include disequilibrium, vertigo, nystagmus, Tullio phenomenon, Hennebert sign, and oscillopsia. Besides audiometric testing, BEMP, BNG, and CT scans are typically included in diagnostic battery. Frenzel glasses are used for evaluation of eye movement without visual fixation. Pressure responses by pneumatic otoscopy or Valsalva maneuvers can be tested for the evaluation of a Hennebert sign. For pediatric patients, conservative management is preferred with the use of hearing aids or and vestibular exercises. Operative intervention may be more beneficial for patients with intractable or debilitating symptoms. The first case is about the pediatric patient. The patient is a 5-year-old boy with a history of recurrent otitis media in both ears. He has operative history of a tympanostomy tube placement in the right ear. He has hearing problems and speech and language delay. CT scan confirmed right SSCD and severe thinning above left superior semicircular canal. He is overly sensitive to ordinary environmental sounds. There were no reports of tinnitus, dizziness, or otalgia. Tympanogram shows mild to moderate hearing loss with a 20 to 25 dB air-bone gap in the frequency range of 250 to 1000 Hertz. Here. Tympanograms are consistent with his case history. The right ear with the P tube revealed a flat tympanogram with large ear canal volume, 11.75. Left ear showed negative pressure tympanograms, negative 249 here. Acoustic reflexes were not tested. Speech thresholds were better than his Puritan thresholds. Speech recognition thresholds, SRT is about 20 for right, 15 for left, but his Puritan average is about 35 for both ears. Word recognition scores are good in both ears. 80% for right ear, 88% for left ear. This slide is for the summation of testing results. And his treatment was managed conservatively with hearing aids. Frequent follow-up visits were recommended for hearing monitoring. He was referred to ENT for further treatment. He was referred to SLP as well. The second case is for an adult patient. The patient is a 49-year-old man. He has experienced severe hypersensitivity to his own body sounds and voice sounds for 8 years. He complains of brief episodes of vertigo triggered by his own humming sound. The right ear was subjectively more affected. Otoscopy was unremarkable. Tuning fork testing revealed negative ringing on both ears, which suggests the conductive components bilaterally. Tympanograms were normal and otoacoustic emissions were intact. Pharyngeal glasses showed no nystagmus after Valsalva maneuvers. So no Hannah-Burt signs. Audiograms show normal air conduction thresholds between 250 and 4,000 hertz. Here. Bone conduction thresholds were supranormal between 250 and 1,000 hertz in both ears. Here. So, air-bone gap was 15 to 45 bilaterally. He has mild high-frequency hearing loss at 8,000 in the right ear here. And also 6,000 hertz. So looks like a noise notch. It's corresponded to moderately severe hearing loss. However, no information was reported about history of noise exposure in a resource article. Another threshold is shown in the bottom of audiogram here. It's about 100 dBH. Higher, actually more than 100 as well. It's between 250, 1,000, 250, 1,000. These thresholds were measured for head movements triggered by brief pulsatile tone, which suggests Tulier phenomenon. VAMP results show enhanced responses and lower thresholds at 65 dBNH. Enhanced responses and threshold at the 65. Normal population have actually thresholds at the larger than 85. So it's a pretty lower thresholds. And because VAMP response is typically absent in the presence of conductive hearing loss associated with the middle ear pathology, the presence of VAMP response with the air-bone gap indicates inner ear pathologies. Video oculography revealed no spontaneous nystagmus with visual fixation, which is shown on the top trace here. And with sound stimulation and without visual suppression, there's a bottom. with sound stimulation, without fixation, without the visual fixation. Actually, this nystagmus was observed on both vertical, horizontal planes. Middle trace here show a left beating horizontal spontaneous nystagmus in darkness, without visual fixation, and without sound stimulation. Here. So only right eye position was tested and reported here. Because the patient reported subjectively, he has more troubles in right ear. Another test was about balance control testing. So the balance control testing revealed reproducible sound-triggered brief trunk movements with the onset of tone presentation. So both test results support the Tulier phenomenon. CT scan confirmed dehiscence on both ears. Here. More for management, hearing aids can be recommended, but the patient has a hypersensitivity to sound. So open feeding to reduce low frequency energy and keeping maximum output of the hearing aids below vamp thresholds may be helpful for the patient. He was referred to ENT for further treatment. If those symptoms become debilitating, operative intervention would be the best treatment option for him. That's why it is very important to monitor his hearing and the vestibular status regularly. SSCD symptoms are caused by dehiscence of the otic capsule overlying the superior semicircular canal, which acts as a third window. One of the major audiologic signs is conductive hearing loss with supranormal BC thresholds in the frequency range of 250 to 1000 Hz. VAMP test is useful in diagnosing SSCD. So actually, it's a great diagnostic tool. Separate SSCD from otosclerosis, because sometimes the audiogram shows a little bit similar, the configurations. So it's a BAMP, that's why BAMP is a good tool to diagnose SSCD. Symptoms typical of SSCD occur in cases with thin but not dehiscent bone. Conductive management is preferred for pediatric patients. Hearing aids and vestibular exercises or vestibular suppressants are options for conservative management. Operative intervention is the best option for patients with incapacitating symptoms. Thank you.